This is your lecture on diuretics. Diuretics can affect arterial dilation, thereby decreasing vascular resistance. This reduces our extracellular fluid volume, plasma volume, and cardiac output, which then decreases our blood pressure. This is a really great picture that shows where all of our diuretics are going to work. Different diuretics are going to work on different places within our kidney. Some are going to work within the nephron itself. Some are going to be working in the proximal convoluted tubule, our descending loop of Henle, our ascending loop of Henle, the distal convoluted tubule, as well as parts of the collecting duct. The two main reasons we would utilize diuretics are for decreasing hypertension and decreasing edema, and that can be peripheral or pulmonary. So diuretics are going to increase our urine flow, which we also call diuresis, through inhibition of sodium and water reabsorption from your kidney tubules. Majority of our electrolytes are going to be lost with use of diuretics, and that includes potassium, magnesium, chloride, and bicarbonate. For majority of our diuretics, we are going to anticipate diuresis. This means we should always assess our blood pressure before we administer, because if the patient is diuresing, they're lowering their circulating blood volume, which will also cause hypotension. We always need to assess our intake and output. Our urine output is included with the eyes and nose, as well as our electrolytes before we administer. The first category of medications we're covering are the carbonic anhydrase inhibitors, or CAIs. These are chemical derivatives of sulfonamide antibiotics. Working on the carbonic anhydrase system, mostly within the kidneys and also the eyes. Predominantly, it will work along the nephron in the proximal tubule. The carbonic anhydrase system is distal to our glomerulus in the proximal tubules, where 2/3 of our sodium and water is reabsorbed into our blood. When using carbonic anhydrase inhibitors, we're inhibiting the carbonic anhydrase system. This means that sodium and water cannot fully be resorbed into the blood, and it's then eliminated through our urine. With reduced formation of the hydrogen and bicarbonate ions from carbon dioxide and water through the non-competitive reversible inhibition of our carbonic anhydrase activity, we have a reduction in mostly hydrogen ions. This can induce a respiratory and metabolic acidosis, which will then increase our oxygenation during periods of hypoxia. That increases our ventilation, cerebral blood flow, and dissociation of oxygen from oxyhemoglobin. This is also especially beneficial for those that are using this to prevent altitude sickness, but it can also cause hyperglycemia and glycosuria. There are 3 different reasons why we would use our CAIs. The first is for glaucoma, and typically we will use these when other medications render ineffective, and that's to help increase the outflow of aqueous humor to reduce the intraocular pressure. We can also use this for edema. Not as commonly used for edema, but it is still something that can be utilized. It's not as effective as our other diuretics, and it's only effective for a maximum of 4 days. So this is another reason why it's not as commonly used. One reason it is pretty commonly used is for altitude sickness. And I haven't used it yet, but I got a prescription for this because I'm planning to do Mount Whitney, and I've already experienced altitude sickness before. So I got this in preparation for doing the summit to Mount Whitney to prevent any sort of altitude sickness. 2 of our biggest contraindications are going to be hyponatremia and hypokalemia. And even though these are structurally related to sulfonamides, it is unlikely to cause a reaction. Main things to note for your adverse effects are metabolic abnormalities with acidosis and hypokalemia. Now, if we have a risk of hypokalemia, we need to be concerned if the patient's also receiving digoxin, because this can potentiate digoxin toxicity. We can also have an interaction with our corticosteroids that can cause hypokalemia. Our prototype drug is acetazolamide or Diamox. This is a pregnancy category C, and we need to make sure that we are assessing renal and hepatic function, electrolytes, especially our sodium and potassium, as well as our intake and output and our patient's blood sugar. Our next category of drugs are loop diuretics, are very potent diuretics that are structurally also related to sulfonamides. However, these two are unlikely to cause a reaction. Our loop diuretics are going to act along the thick ascending loop of Henle, blocking chloride and sodium reabsorption. This also has possibility to activate our renal prostaglandins, which then cause dilation of our blood vessels to the kidneys, pulmonary, and systemic circulation. This is then going to reduce our preload and central venous pressure to help reduce overall blood pressure. We utilize this most commonly in the acute care setting for rapid diuresis. So, for example, a patient comes in, they're short of breath, we listen to their lung sounds and we can hear fluid. We call that crackles. If the patient is struggling to breathe, we need to diurese them. To quickly diurese them, we will give a loop diuretic. It's effective in just one dose, and it's pretty great that it can increase our renal blood flow. So even if a patient has impaired renal function, it can be very effective. However, if they are in severe renal failure, we would not want to use this drug. If we're saying that we're going to have massive diuresis, can you think of some electrolytes that are going to be off after we give this drug? If you're thinking potassium and sodium, you are correct. So we will see hyponatremia and hypokalemia. More commonly, it's going to be your hypokalemia. So we will expect to see a drop in your potassium levels after administering this drug, which means we must check our potassium levels before we give this drug. So predominantly our indications are going to be edema associated with heart failure, hepatic or renal disease, and acute leak for pulmonary edema if we need to rapidly diurese our patient. The contraindications are a very severe electrolyte loss, mostly our potassium, dehydration, and hypotension. We absolutely need to be checking our blood pressure before we give this medication. I had a coworker once who was a little bit behind, needed to give their medications, was not being diligent in assessing the patient prior to administering, gave 40 milligrams of Lasix, which is a pretty healthy dose, and then checked the patient's blood pressure after giving an IV dose. Their blood pressure was in the 70s. That was some panic that ensued after that because she knew that that patient was going to diurese and become hypovolemic. So they had to watch the patient pretty closely and ended up giving something called albumin, which is a plasma volume expander, which helped bring the blood pressure up a little bit. But the patient definitely became more hypotensive after that. So please always make sure that you check your blood pressure before you give this medication. So adverse effects, kind of just like we talked about, hypotension, hypovolemic shock, and we can have dysrhythmias if our potassium level becomes too low. If you're giving this IV and you push this too fast, it can cause ototoxicity, so it's very important you don't push it too fast. For toxicity and managing an overdose, we always need to make sure, watch those potassium levels and make sure your intake and output is balanced. If the patient is putting out a lot more than they're taking in, we may need to give them more fluids. If we don't do that, they can go into circulatory failure, and we likely will need to put them on a vasopressor in the ICU. The picture in the slideshow is a good indication to show you what edema looks like. So on the left side of the screen, you can see what looks like an indentation on the patient's shin. That's what we would call pitting edema. When somebody has severe edema and you push down on a bony prominence, so somewhere over a bone, and their skin does not return, that would be pitting edema. On the other side, you can see pulmonary edema, and that is when our alveoli are full of fluid. When that happens, we can't have adequate CO2 exchange, and the patient becomes hypoxic. Our prototype drug is furosemide or Lasix. This is our most commonly used loop diuretic, and it stands for Lasix lasts 6 hours. So that's a good way to remember the name. There is a black box warning for fluid and electrolyte loss because it can cause significant diuresis. Again, we must check our blood pressure, our urine output, renal function, and potassium levels before we administer. And again, we have to give this pretty slowly because we don't want to cause ototoxicity. For our onset, peak, half-life, and duration, you should be familiar with the onset, peak, half-life, and duration of both your IV and PO formulary. Our next category of drugs, osmotic diuretics, are going to work alongside the entire nephron. The major site of action is the proximal tubule and descending limb of the loop of Henle. This is going to increase the osmotic pressure in the glomerular filtrate. Also, it's going to inhibit tubular reabsorption of water and solutes. This causes rapid diuresis to reduce cellular edema. This will then increase urine production and cause diuresis. We do not have a significant loss of electrolytes with our osmotic diuretics, so it is not going to be helpful for peripheral edema. It does also induce vasodilation, which increases glomerular filtration and renal plasma flow. So this does help in preventing renal injury with acute renal failure. We give this for early oliguric renal failure, and oliguric means low urine output. We also commonly use this in the neurosurgical ICU to reduce intracranial pressure in neurologic emergencies. So if we have a patient that comes in, let's say they have a brain tumor that is now pushing on their brainstem. This is a life-threatening emergency. We need to alleviate that pressure as soon as we possibly can, otherwise the patient will herniate. Your brain has nowhere else to go but down when you have increasing pressure. And if herniation occurs, the patient will die. So we give mannitol, which we'll talk about in just a moment, as our osmotic diuretic to help decrease that cerebral edema as fast as we possibly can. Time is essential in these situations. Contraindications: pulmonary edema, active intracranial bleeding, severe dehydration, and severe renal disease. Our prototype drug, as I have just spoken of, is mannitol or osmotrol. It is a pregnancy category C and only available parenterally. It can crystallize at low temperatures, and I actually included a picture from when I went to open our Pyxis and pull out a dose of mannitol. You can see that it exploded and it crystallized. So the temperature must have been extremely low inside that Pyxis for this to happen. I've never seen this occur, so that's why I took a picture when it happened to be able to show you firsthand what that looks like. So we also do have to use a filter because of the risk of crystallization. And just a picture on the right so you can see what an edematous brain looks like on the top and a normal brain looks like on the bottom. Our next category of drug are potassium-sparing diuretics. Those are going to work in the collecting ducts and distal convoluted tubules to interfere with sodium and potassium exchange. These are not going to be as potent as our loop or thiazides, but we utilize them as an adjunct. We can combine them with potassium sparing and our other diuretics to create a synergistic effect and also even counteract our metabolic effects. So if we give a medication that causes hypokalemia and we give a potassium sparing diuretic, we're balancing that out. We can give this for hyperaldosteronism, polycystic ovarian syndrome, heart failure, hypertension, and ascites from liver failure. Contraindications are going to be hyperkalemia because we're holding onto our potassium, severe renal failure, and anuria. And anuria means no urine output because when you have a word with a in front of it, that means without. Our adverse effects: gynecomastia is pretty common with our potassium-sparing diuretics, and gynecomastia means increase in breast tissue, and that's mostly problematic in our male population. Amenorrhea, irregular menses, postmenopausal bleeding, and hyperkalemia. We should not concurrently utilize these with our ACEIs or potassium supplements due to the risk of hyperkalemia. Our prototype medication is spironolactone or aldactone. This is a pregnancy category D. This drug is going to competitively bind to our aldosterone receptors to block resorption of sodium in water that's induced by our aldosterone secretion in our distal tubule. It is a synthetic steroid that blocks aldosterone receptors, and we must assess our potassium levels and educate our patient to avoid any potassium-rich foods or supplements. And just interesting to note, Mrs. Dash has a potassium-free seasoning, so something good that we can educate our patient on. The onset is 1 to 3 days. Our peak is 2 to 3 days, a half-life of 13 to 24 hours, and a duration of 2 to 3 days. And on the right, I just wanted to include a picture so you could have a visual of what ascites looks like. On the left, you'll see a normal peritoneum, and on the right, you see that it's filled with fluid. The patient almost looks as if they're pregnant. However, it looks different because the skin is going to be very, very taut with spider hemangiomas around the skin. So it'll look very much like pregnancy, but different. And our final category are thiazide and thiazide-like diuretics. The primary site of action is going to be the distal convoluted tubule to inhibit reabsorption of sodium, potassium, and chloride. This leads to osmotic water loss. It also causes a direct relaxation of our arterioles to reduce peripheral vascular resistance, which is also known as our afterload. If our renal function does decrease, efficacy of thiazides does diminish due to impaired delivery of the drug to the site of the receptor. We can use this for hypertension, edema, idiopathic hypercalciuria, idiopathic meaning we don't know the reason why, diabetes insipidus, and as an adjunct for our patients with heart failure and hepatic cirrhosis. Contraindications are anuria and severe renal failure. Adverse effects to watch for: hypokalemia, hyperglycemia, and hyperuricemia. For toxicity and management of overdose, it's mostly due to our electrolyte abnormalities. Hypokalemia can cause anorexia, lethargy, weakness, mental confusion, and hypotension. Our first prototype drug, hydrochlorothiazide, also known as HCTZ. This is a pregnancy category B and usually is combined with other medications. It can be combined with methyl-dopa, propranolol, spironolactone, triamterene, hydralazine, our ACEIs, beta blockers, and labetalol. And this is only available PO. Our onset is 2 hours. The peak is 4 to 6 hours, half-life of 5 to 15 hours, and a duration of 6 to 12 hours. And our next drug, metolazone or zeroxolin, is a pregnancy category B. This is a thiazide-like diuretic that has more potency than our thiazides. It can be combined with our loop diuretics that is useful in our patients with moderate to severe symptoms of heart failure. Typically, we like to give metolazone 30 minutes before the loop diuretic. The onset is 1 hour, with a peak of 1 to 2 hours, a half-life of 6 to 20 hours, and a duration of 24 hours.